It is my pleasure to introduce Dr. Kim Allen Williams. In March 2015, at the convocation ceremony at the American College of Cardiology annual scientific session in San Diego, California, the convocation speech was given by the then president, Dr. Kim Allen Williams. The takeaway points from that lecture were quite profound. Dr. Williams is a chief of the Division of Cardiology at Rush University and specializes in cardiology prevention and cardiac imaging. He has served on numerous national committees and boards, including serving as the president of the American College of Cardiology, president of the American Society of Nuclear Cardiology, and chairman of the board of directors of the Association of Black Cardiologists, ABC. He's also the founder of the Urban Cardiology Initiative in Detroit, Michigan, which serves to reduce ethnic heart care disparities and continues community-based efforts in Chicago at Rush University. His current professional focus is on preventive cardiology, specializing in synthesizing data on cardiovascular risk and mortality due to nutrition. He has become a nationally and internationally recognized speaker, including over 200 publications, online resources, movies, can we say YouTube, and lectures on the topic of cardio nutrition. He was recently awarded the Lifetime Achievement Recognition from ASNC as his 2018 Maria Verani Lecturer and the German Cardiac Society as his 2019 Gold Key recipient and keynote lecturer. A native of Chicago's South Side, Dr. Williams has over 30 years of experience as a brilliant educator, researcher, and physician. Let's listen attentively as he speaks to us about cardio nutrition. This is one of the simplest, if not the easiest way to achieve the goal of reducing cardiovascular disease. Let's welcome Dr. Kim Williams.
Well, good morning, everyone. I'm Dr. Kim Allen Williams, and I am the James B. Herrick Professor and Chief of the Division of Cardiology at Rush University Medical Center. And I'm actually a past president of the American College of Cardiology. For those of you who remember those remote days 5 years ago, I was actually at the Kentucky chapter, and it's good to see you all again. Hopefully we'll be able to do something again in person at the end of this pandemic. My topic today is to try and discuss nutrition and how it relates to cardiovascular mortality. But I kind of made a rule at Rush University that you should never give a lecture during a pandemic without talking about the pandemic. So I actually am going to start by referencing the last time that cardiovascular disease was not the #1 killer of Americans. That was 1918. So you're actually seeing sort of the precursor to the COVID epidemic that we're living through now. It was really horrific, the number of people who died. And it's very similar to what's going on with right now. And the way it was spread, the way that masking and distancing seemed to help. But I don't want to just talk about the fact that we're in a viral pandemic. I want to talk about the fact that so many people catch the virus and they do fine. And then there are other people who catch the virus and they do not do fine. And we've gotten so much data from our CDC and from around the world, actually, about what it is that makes people have an increased risk for a severe COVID-19 illness. And it turns out that it's the exact same situation that we have with cardiovascular disease. If we sure there's chronic obstructive pulmonary disease, but it's diabetes, it's obesity, and it's hypercholesterolemia, and hypertension. And if we were to actually focus on our efforts on reversing the reversible portion of that risk, we would be doing so much better with the COVID epidemic. Sure, people would get sick, people would contract the illness and they would spread it, but they wouldn't spread it quite as much. is particularly true for our African American and Hispanic population, where in location after location, including New York, where it's more about Hispanics than Blacks, but very close. But what we really have is a situation where the risk factors are actually what's determining the outcome. It's not just race, it really is risk. And so at Rush University, we have a large database because we surged up and took the majority of the people, more than any other hospital system in the Chicagoland area. And so we have a very large database, and it confirmed what was found in Louisiana in a publication in the New England Journal of Medicine a few weeks ago, that if you controlled for the risk factors, it turns out that being Black does not increase your risk of dying from COVID. It actually is slightly protective, maybe not statistically all that significantly, but the problem is the risk factors, not the race. If you are obese, you're going to have more problems with this. You're going to have underlying cardiovascular disease, sure, but diabetes is a major issue. Why? Because people end up with a poor immune system. What is it about high cholesterol? The virus loves to reproduce in the serum when there's a lot of cholesterol around. What is it about obesity? It turns out that invasion of the adipocyte and reproduction within the adipocyte is what COVID-19 really wants to do. That virus ends up replicating itself so well in fat cells that the people who are overweight, obese, and morbidly obese end up with a much higher level of viral particles. They're spreading it more. They're shedding virus constantly. And they end up with much more severe illness and with respiratory complaints. And of course, the obese people are the people who are not going to be easily ventilated when they have a large demand for oxygen and a limited supply because of the lung disease that's happening. What's wrong with hypertensive people? There's no clear answer there, but it probably has to do coexistence of other cardiovascular diseases as well as obesity. But there is going to be some underlying vascular damage. And this is a virus that likes to create its own set of vascular damage, and perhaps the two are piling up on each other. So if we look at the Italian or the Chinese experience and the United States, it's the risk factors that determine how well someone's going to do. So why am I talking about this in a nutrition talk? This is a slide from PCRM. As you can see, talking about the fact that if we were to improve our diets, we would decrease the diabetes. That's been shown, and I'll talk about it today. We would decrease our obesity. We would improve our blood pressure. We would lower the cholesterol. And if we could do all of those things, all of a sudden, we may not stop COVID-19 from spreading around, but we would have less viral particles going around, less severe illness in folks, and less difficulty with morbidity, mortality, and usurping all of our medical resources. So something that we all should be thinking about. Let's fix the diets of the American population. And now we'll spend more time talking about why. I can't talk about the fact that we have this ethnic difference in outcomes without mentioning the fact that it was already there. Starting about 40 years ago, we noted that as we were improving healthcare and cardiac care, development of coronary care units and stents and bypasses and statins and everything else, the African-American population in the United States got a little less of the improvement. And so we end up with a higher mortality, about a 21% higher mortality even now than the rest of the population. And this is something that we should be able to do. It's been a pandemic. I mentioned the Spanish flu epidemic. I would love for heart disease to be number 2 in the United States in terms of cause of death. It was number 2 in 1918, and it's been number 1 ever since. So we have to recognize how global this is and how cancer has taken over in many of the high-income countries, but not the United States. And the low and middle-income countries suffer as well as we do with heart and circulatory disorders being number 1. You see that on this slide. It really is remarkable that with all of the advances that we've made to help, everything from HIV to, communicable diseases, we leave them with the kind of lifestyle that leads to cardiovascular mortality, a lot of it based on nutrition. And that's certainly true here in the United States. So we have this burden of cardiovascular disease with one death every 40 seconds. It's a massive amount of money, and it is definitely disproportionate, with nearly half of our African American population having at least some form of cardiovascular disease. If you get out of the United States and look globally, you see some very startling numbers that have been analyzed and published. 11 million deaths and 250 million disability-adjusted life years that are attributable to dietary risk factors. If you're eating a lot of saturated fat, eating cholesterol, not enough fruits and vegetables and grains, eating a lot of sodium, eating sugar-sweetened beverages, all of these actually add up to detract from the health of the human population globally, not just in the United States, but especially in the United States. And so you can look at the other side of that graph without the racial difference and look at how well we've done as a cardiology specialty, incredibly well. But you could actually characterize all of that as mopping up the floor with all of our stents and bypass surgeries. We actually do have some pretty good mops, but at some point we have to consider turning off the faucet. And to do that, we need much more of a focus on prevention. And hopefully everyone will get that, because if we don't, this is what happens. In fact, it did happen. In 2015, that dramatic 70% decrease in cardiovascular mortality stopped. And we've had a slight rise in cardiovascular mortality in the United States ever since, every year, year over year. And so where is it going to stop? Well, the CDC says that it's obesity and diabetes that are driving it. And this is something that we need to talk about, because we can make the dietary interventions to make this pandemic go away on both sides. So the epidemic of cardiovascular disease has been noted. People dying younger. This is a Wall Street Journal picture that actually talked about African Americans, because that's the population that's being hit the most. And these are things that we really can improve. The diabetes, the obesity, hypertension, hyperlipidemia, if we actually focus on these, we would be able to improve our outcomes and lower our healthcare costs dramatically. So let's talk about some of the obesity factors that are dietary. The dietary fats that have been associated with mortality are really interesting to look at, because we have taken a stand as a country against the use of trans fats. And it turns out that the improvement in mortality that you can get by getting rid of saturated fat as well as trans fats has been documented, replacing them with polyunsaturated fat and monounsaturated fat. And you really can get substantial reductions in mortality if we make that change in our diets. And a lot of that has to do with changing saturated fat and all the things that go along with it, which is animal products, and removing those and putting more vegetable fat, if you have to have fat at all, but more fruits and vegetables. This actually has infiltrated our American College of Cardiology, American Heart Association guidelines. It turns out that we were able to synthesize all of the modern literature for primary prevention, which is really what we need to turn off that faucet. No one should be smoking. Everybody should be aware of their cholesterol, have a normal blood pressure, make sure that they're getting an appropriate amount of physical activity, at least 150 minutes per week, unless you're doing something that's really vigorous. And using aspirin only in the people who are extremely high risk, not just the routine diabetics with no underpinning cardiology issues, and making sure that we focus on diet. This is the opportunity to improve things in such a way that folks will have a better outcome. To deal with this obesity epidemic, we need intervention. We need to stop with the refined grains, red meat, unhealthy fats, sugary drinks, and focus on fruits, vegetables, whole grains, and nuts. We need to make sure that the people who are most at risk are understanding that. And this graph is, showing that it's not evenly distributed among the American population. And in fact, if you include the overweight population, the African-American women, actually, that number would be about 80%. It is really important to recognize how difficult it is for as a risk factor for death around the world. It's not just the United States, but it's a growing problem everywhere, no pun intended, along with the smoking and high blood pressure, as well as diabetes. One of the issues that makes it happen is fast food. Now, either we're going to have to change the habits of people, or we're going to have to change the fast food so it doesn't have so much sodium, saturated fat, cholesterol, and processed meats. If we do that, we are going to improve the health of the population, because so many people are doing fast food on a daily basis. One of the major things that people need to understand is that they're eating too many calories. If they're eating a lot of oil, people joke, well, it's not a joke. The fat you eat is the fat you wear. If you're eating animal products, they're very calorie dense. And so if you're sort of a caveman and you're only going to live to 35 or 45 years old, and you can down a mountain lion or whatever and eat it, it'll keep you from starving. But in a land of plenty, it really becomes the diet for long-term survival, which we'll get into, is going to be predominantly plant-based, if not exclusively. We don't need to supersize things. And that is something that's been happening gradually with marketing and the use of the fried foods, the red meat, the refined grains, and then sugar-sweetened beverages that have gotten larger and larger in size as our appetites and our waistlines increase. So let's intervene. You'll notice that some of these diets have names that you recognize. Atkins with his low-carb approach that I'll specifically talk about in a few minutes. Dean Ornish with the completely plant-based diet. Weight Watchers with making sure that people know how many calories they're actually eating. Look how successful they are. They actually are all successful. The plant-based one has the best one for in that study for longevity, the Mike Danziger trial from 15 years ago. If you look at an intervention in which Turner-McGreevy did at Medical University of South Carolina, it turns out that the plant-based diet does have more sustained outcome and lower weights and better weight loss. So this is a pattern. It changes the entire approach to eating. And as you eat more vegetables and less animal products, you end up with less calorie density. Now, to focus on diabetes and hypertension, now that we've cured the obesity issue, remember how important it is. And look, again, this is all around the world. And it's not just a big deal in all-cause death, but in cardiovascular death specifically, it is number one. Can we approach that with diet? What do the observational data say? It's actually fairly clear from Adventist Health Studies 1 and 2, where they have a congregation of people who are willing to fill out food frequency questionnaires over long periods of time, and they have 30 years of follow-up. If you're doing a completely plant-based vegan diet, you're going to have a better outcome than the lacto-ovo-vegetarians, which is better than eating fish, which is better than just cutting the meat, which is better than having a full-on American diet. By better, what I mean is, in terms of the obesity, the only group in the Adventist Health Study that is not on average overweight, that is a body mass index greater than 25, is the completely plant-based diet. The incidence of diabetes is very low, comparatively speaking, and the incidence of hypertension is very low. You notice that if you look at those hazard ratios or prevalences, you will actually see that they improve with every change you make. And so people will say, well, I want to be a flexitarian. And I would say that, yeah, if you only want to reduce your bad outcomes and your risk factors by 20, 25%, then that's fine. But every time you change, go from red meat to fish, go from fish to dairy, and then leaving them all off, going to completely plant-based, you're making yourself and your risk factors better. Does it translate to mortality? Not just an issue of improving risk. And it turns out that those risk factors are real. And you get a 20 to 30% decrease in cardiovascular mortality or all-cause mortality if the more vegetarian you are, particularly for men. Love this slide from the Adventist Health Studies showing that as you get older and older, the number of people doing plant-based nutrition on a relative basis increases, and the people eating the standard American diet unfortunately goes down and down and down, partly because they're switching, I hope, but more than likely a lot of them it's actually mortality. Because it is the vegetarian Adventists that actually live about a decade longer. But, it's not just about living longer. It's about living fuller, being less overweight, 30 pounds lighter. And that means that they're going to be, less in pain in their knees and in the spine, and less degenerative disease, more activity, running up the mountains instead of just staring at it from the seat of a car. And so we would like to see people have not just longer lives, but improved lives. And that's the way to do that. It would be to improve the nutrition as well as do the exercises we've recommended. So how about the blood pressure if you were to not just do observational studies, but to do an intervention? And it turns out that there is a large amount of data which we have quoted in our hypertension guidelines. And one of the pillars of the guidelines is non-pharmacologic therapy. We can do that and, because we do have the ability to look at predominantly plant-based interventions. And the more vegetarian you are, the lower the blood pressure is going to be. The DASH diet showed that as well. If you take the DASH eating plan, which is to lower sodium and saturated fat, and then you take the group who were very low in fat and very low in cholesterol, which means predominantly vegetarian, you see the most dramatic reductions in blood pressure. And so that has made it to our guidelines. Everybody should be doing physical activity, cutting back on the alcohol consumption. They should be losing weight. They should be lowering the sodium to less than 1,500 milligrams a day, enhancing the potassium to 3,500 milligrams to 5,000. But they should be doing a healthy diet because that is the one that is actually going to get the largest change in the blood pressure for the intervention at 11 millimeters of mercury. I'm going to switch over and talk a little bit more about diabetes and sugar and sweeteners, because there is a lot of data talking about how nowadays we can improve cardiovascular outcomes with the medications, particularly the GLP-1 and SGLT2 inhibitors. And so this is an area that all of you as cardiologists are going to become more and more familiar with, because you can actually improve the outcomes of the patients who are diabetic. But how about getting rid of the diabetes? Well, one of the best ways of doing it is to not let the insulin levels ever get really high. Insulin goes up when you get a glucose or fructose or sucrose load or white bread, because it's refined grains. And there's a dose response that shows you that the more you take, the higher your plasma insulin is going to be. What's wrong with that? Well, it's an amazing growth hormone. And so it'll grow plaque, it'll grow adipose cells. And that ends up causing more insulin resistance, which would then therefore mean that you're going to actually increase insulin even more and have more of this growth hormone around. That hyperinsulinemia accelerates atherosclerosis, as does the vascular effects causing essential hypertension, hypertriglyceridemia, and even clinical diabetes. So let's try and back away from this. We should also talk about saturated fat in this regard, because we have data that says that if you are taking a lot of saturated fat and you're eating a lot of red meat, you can actually get more glucose intolerance and insulin resistance. And so we need to back away from those things. It'll improve your total cholesterol, improve your triglyceride level, and not glycate your LDL cholesterol. And people really shouldn't drink calories. I know this is something that you see in the marketing. You see everything from sports drinks to people doing fruit juices. But remember that every 50-gram dose increases your high sensitivity C-reactive protein. And it just takes a short amount of time to have your inflammatory markers go up. And those inflammatory markers actually stay there over a 2-hour period. So this is something people need to back away from and try to do plain fluids that don't have the sugar load. What's wrong with having your inflammation go up? Well, and glycating your LDL, it does translate to mortality. And you hear the idea that everyone should be backing away from added sugar, moving from 10% down to 8%, which is the preliminary recommendation for the dietary guidelines from the United States for 2020. And I'm glad to see that. I know the Sugar Research Foundation is not so happy to see that people are backing away from the product, but this getting away from where that mortality ratio, the adjusted hazard ratio, gets away from unity is something that we all should be focusing on. Have to throw in a little data on low-calorie sweeteners because they actually do cause mortality as well. And there's a wonderful science advisory from the American Heart Association about that. If we look at the Nurses' Health Study, we actually see that the sugar load that people have been doing up in the right-hand corner is actually numerically worse than eating a cholesterol load in terms of the hazard ratio. And both of them could be improved dramatically by moving to vegetable fiber, which would improve mortality rather than increase it. If we talk about going back to the artificial sweetener issue, we actually do have good data that says the sugar increases the mortality by about 31%, as opposed to the artificial sweeteners where it's closer to 13%. Okay, so we understand that there's an association there. But how about specifically analyzing how plant-based you are and whether or not you get diabetes? Well, there is some good data published in JAMA last year that was a meta-analysis of multiple studies, some of them showing really dramatic reversals or relationship between how plant-based you are and whether or not you develop diabetes, similar to what was shown in Adventist Health Study 1 and 2. And so there actually is a line that's fairly linear. The more plants you're eating, the less diabetes you get. And I wish this was a message that everyone would hear and change the diets. We could change this disease and change the outcomes, not just for cardiovascular disease, but for COVID as well. Okay, how about intervention? Let's do, like you saw with the hypertension, another PCRM analysis. You actually take the studies, put them together, and it turns out if you intervene with a plant-based regimen, you are able, with a low-fat vegan diet, and not so much with the lacto-ovo-vegetarian, but with the low-fat vegan diet, you are able to decrease hemoglobin A1C significantly. Have to throw in this one that seems out of place, but if we're going to talk about doing plant-based diet to improve hemoglobin A1C, got to see this data. It's not just A1C, it's their weight, it's total cholesterol, it's LDL cholesterol, but on top of it, it's quality of life, feeling well about yourself, having less depression. All of those happen when the disease is resolving. People feel good and they feel good about themselves. So this is probably, I would think, is one of the best reasons to adopt plant-based diet in the diabetic, because they're going to feel so much better as well as having better outcomes. Have to throw in this one about sugar-sweetened beverages and taking the gumption, which these folks did, to actually ban them in Northern California. The background being that the sugar-sweetened beverages are attributable, or 180,000 deaths are attributable to the sugar-sweetened beverages, and it's something that is an option. People could actually do unsweetened tea or a lot of wonderful options that don't have to have sugar. Well, what they were able to show is that if you were to make an intervention by banning it at the workplace, you could actually change how people behave and even how they behave at home. And so I'm hoping that people will look at this and have the determination to go ahead and put bans on sugar-sweetened beverages. We actually had a tax on it in the Chicagoland area a few years ago. It was promptly turned over or overturned by the lobbying efforts. And, it was very sad to see mostly people who are overweight and obese arguing against this, not realizing how much it was going to increase their mortality. And, like I like to tell my patients, this stuff might be sweet, but there is no food, there's no drink that tastes better than your health. So to sum up the diabetes section, we have an association with refined carbohydrates, fat, red meat. If we reduce those things, we actually will lower our diabetes rates as well as our weight and improve our outcomes, not just long-term, but short-term as well. So let's talk a little bit more about the fat, because you hear over and over again that fat is actually good for you, or fat is back and butter is back. Well, how does that sit? Well, if you look at the pure trials, and there's several of them out there, and they tend to say things that you think are a bit unusual. In this one, they were saying that fat is way better than carbohydrates. Well, if you actually look at their methods, what they're saying is actually true, and we covered it already. It was true in the Nurses' Health Study. That is, the carbohydrates that they were using in these countries tended to be the very refined white rice, white sugar, white flour. And if you do those, you actually do increase your mortality more than you would by doing even saturated fat. So we try to get people to get away from refined carbohydrates. And I wish the authors, Salim Yusuf is a good friend, but I wish he had put high refined carbohydrate intake, because that's actually what they were showing. It is important to try to replace those with polyunsaturated, but also I would say change the refined grains to those whole grains, and that'll make a big difference. There is a nice presidential advisory from the American Heart Association a couple of years ago talking specifically about this, that if we cut down on the saturated fat and use unsaturated fat as well, we will have an improvement in lipids, atherosclerosis, and cardiovascular outcomes. I don't need to spend too much time talking about trans fats because those are now banned in the United States, but they banned it based on the data from New York saying that it increased stroke and diabetes and heart attack. And it turns out that it's lowering the good cholesterol, raising the bad cholesterol. And it's good to know that the United States is the fourth country to restrict or prohibit it in food service establishments. So you can't just walk to the corner restaurant and be served trans fats anymore. Now, I talked a little bit about inflammation, but now I want to focus on both cholesterol and inflammation, because people have a lot of misunderstanding about cholesterol in food. You could just do an search engine and take a good look at it. And what you'd see is that pretty much all the animal products, with very few exceptions, have cholesterol, and that the vegetable products do not. And some people will argue that there's nanograms. Well, that's not enough to change your serum cholesterol. And we actually do have 3 animal products that don't have cholesterol. That's egg whites, Jell-O, and honey. But the last 2 either have sugar or artificial sugar, or reduce or induce an insulin spike. And so that leaves you with egg whites. The problem with egg whites in this country is that most people eat it with egg yolks, which is a massive amount of cholesterol per 100 grams. Can we lower it with an intervention? And the answer is absolutely. So this is from 2003, Journal of the American Medical Association, with a so-called dietary portfolio, or the portfolio diet, where they actually compared a really reasonable, un-Americanly healthy, low saturated fat diet, but it did have animal products. That same diet plus lovastatin, a low-dose statin, and versus plant sterols, viscous fibers, soy protein, and almonds. And when you put all that together and look at the outcomes, you'd see that not just the C-reactive protein on the right, but the LDL cholesterol on the left were dramatically improved both by the statin and by the dietary intervention compared to the low-fat diet, the controlled diet. As long as people are eating animals, they're never going to get the significant drop in the LDL cholesterol that we need for plaque regression and plaque stabilization. It was also published more recently that, and sort of reproducing that data with the EVADE trial, This was not using the same exact portfolio diet formula with the fiber and the almonds, but it was a whole food plant-based diet. And when they compared that with the American Heart Association diet that does have some reduced red meat and more chicken and fish, what you ended up with is a significant drop in inflammation with the plant-based intervention. And there was no significant change when you looked at the American Heart Association diet. Kudos to the American Heart Association diet for publishing that their diet was not useful, but at least we understand that the plant-based diet can lower the risk by lowering the C-reactive protein. If you go back and take a look at the cholesterol, we have yet another PCRM, Neil Barnhart meta-analysis. This time there's more data density than there was even with hypertension or the diabetes. And you see it very clearly, with few exceptions, when you do a plant-based diet, you are going to see a drop in serum cholesterol. And if you get it down to, the amount of lowering, you are substantially lowering future cardiovascular events. Now let's take a look at some of these dietary patterns and mortality, because there's a lot of misunderstanding. I think most people do understand that it's not a free ride, particularly for our African American population, eating so-called soul food when they should be eating what we call soil food. That's a Milton Mills line that I would borrow to try to get our African American population to be more plant-based. Because the Southern diet, which was published by the Regards folks, Regards looking for reasons for geographic and racial differences in stroke, University of Alabama, right in the middle of the stroke belt, trying to figure out what are the things that make the stroke rate so high, particularly in African Americans. Well, what they've discovered is it's the food. And so the Southern diet has the worst mortality. It actually, as shown in red there, and it actually is true for heart disease, for stroke, for death in patients with renal insufficiency. You eat the fried food, refined grains, not just yams, but candied yams, not just tea, but sweetened tea. And you're putting a lot of saturated fat and cholesterol into the system and having a bad cardiovascular outcome. Now, having learned that lesson, we actually have some data from other databases. And this one actually shows exactly what are the things that we shouldn't be eating. One is a high amount of sodium. That's in the Regards trial. Another one is high processed or any processed meat greater than 0 grams per day. That increases mortality. So the bacon, the hot dogs, all of those things that are in the Southern diet, and frankly in other people's diets as well. Not enough fruit, not enough vegetables, sugar sweetened beverages, not just high, but greater than 0, which means any, all increase the mortality rate. And so these are the things on which our guidelines are written to try to reduce the unhealthful aspects of the American diet. Speaking of which, we have to acknowledge that in the world of plant-based nutrition, there are several camps. There are the people who are concerned about the environment. There are people who are, and they make a good point. That is, if you stopped feeding grain to its captive animals and farm animals, you would actually decrease greenhouse gases, and you could actually feed the entire world's population from the United States alone. And then you have the animal rights people who are concerned about how these animals are treated. Not all of those groups are concerned about cardiovascular disease, and so you will see people eating things that don't have a face and don't have a mother, but they aren't healthy. So taking a potato and frying it, taking grains and removing the husk and the bran so that it's just this kernel of great tasting, but not good for you, insulin increasing type of diets. These are the kinds of things that actually will hurt human health. And you're going to be surprised if you haven't seen this Sagita article before. If you compare a healthy plant-based diet to an unhealthy one, and then compare on the right the upward going lines, the higher hazard ratio, it turns out that the red line is a animal-based diet, and the dashed line above it is an unhealthy plant-based diet. So an unhealthy plant-based diet is actually worse. The next pattern I need to talk about is the ketogenic diet. I have to admit that I was stunned earlier in the week to get a very profane email from one of the supporters of ketogenic diet, referring me, calling me a bunch of names. That I sent them a note back saying I appreciate their input and didn't respond in kind. But they were actually talking about how this diet can lower diabetes. Well, let's talk about that. Why does it lower diabetes? This is a picture of Atkins, and this is a picture of his results. If you lose that much weight, you will actually decrease your insulin resistance in a tremendous fashion. There's no question about that. And that has never been, if that person is listening to this lecture, they'll realize that I've never actually said that it didn't work to improve diabetes, but that's not the problem. The problem is this. If you are a cardiologist, you're seeing these patients, the low-carb diet decreases long-term survival. It was shown in Greece. There's a 22% increase in mortality. It was shown in Japan. They mixed their data together with others, a 31% increase in mortality. Then there was the Seidelman article from our own United States Atherosclerosis Risk in Communities, the ERIC trial. And people could criticize me for quoting the data, but the data is published. So really not criticizing me, they're criticizing the authors and the reviewers and the publishers. But this is Lancet Public Health. I think they were pretty careful. And what they showed is this. If you were doing this from plants, it decreases mortality. If you were doing a low-carb diet from animals, it increases mortality. About 18% increase or 18% decrease if you were doing it with plants. And the more low-carb, the more ketogenic the diet, the higher the mortality rate. No question about it. Now, for the cardiologists, everyone needs to know this data, again, published in the Journal of the American Heart Association a few years ago, showing very clearly that if you were doing a low-carb diet from animal sources and you were post-myocardial infarction, it was a 53% increase in cardiovascular mortality. So please, this is not a diet that people should be using for weight loss or diabetes. We've had multiple publications. This is in the journal Obesity, talking specifically about how it increases inflammation, it increases serum cholesterol, and they go through all of the biochemical analysis before and after, showing that that is the case. That culminated in an article, a review article by the National Lipid Association in the Journal of Clinical Lipidology. It was very clear that if you were doing this, your weight will go down, your hemoglobin A1C will go down, but your risk is actually going up because of the LDL cholesterol and the C-reactive protein. So let's spend a moment talking about the things that underpin the increase in mortality. Well, part of it is that people are eating eggs. And because they're very low in carbohydrate, high in protein, but unfortunately they have some of the issues that make mortality, such as cholesterol. And there is a linear relationship between egg consumption and mortality. How much do you have to eat in order to die faster? Well, in that population, which was fairly large, each additional 300 milligrams of cholesterol was significantly associated with a higher risk of cardiovascular disease. Now, it turns out, and all-cause mortality. Now, it turns out that that hazard ratio may be about the same, but how much reaches statistical significance really depends on how large the sample size is. And the size of folks doing in the United States eating eggs is very substantial. What they need to know is that each additional half an egg is associated with a higher risk of incident cardiovascular disease development, as well as all-cause mortality. But it's not just eggs. It's also red meat. And it turns out that red meat consumption increases mortality. We've known that for a while, that red meat kills and processed red meat kills faster. And so looking at the curves for the increase in the hazard ratio, for those people who say anything in moderation, just remember that the slope is greatest between 0 and 1 serving per day. So we should probably be doing substantially less than that if we want to have a good outcome. We always talk about heart attack, stroke, and death, but we really should be mentioning heart failure as well. There's important publications that connect processed meat and particularly, but unprocessed meat as well, but particularly processed meat to increase heart failure mortality with a hazard ratio that's higher than you see from most cardiovascular studies. Now let's talk about the Mediterranean diet. I think that this one is the one that gets more misunderstanding as time goes on, even though the data is actually very clear. For those of you who haven't seen it, it was retracted from 2013 and was republished in 2018 in New England Journal of Medicine. And both publications said about the same thing, that if you look in the upper left-hand corner, panel A, it's about a 30% decrease in the combined endpoint of heart attack, stroke, and death from myocardial infarction. And it didn't seem to matter much whether it was done away from the control diet, which was doing more chicken and fish or more poultry and fish, and away from red meat, and then supplementing with extra virgin olive oil and nuts, or nuts in a randomized fashion. And so that design was actually very good in terms of the follow-up. And once they solved their randomization issues, it got published again. It was chosen in 2019 by the U.S. News and World Report as the #1 diet for human health. But what I fail really to understand for people who are making a recommendation to do or themselves eating a Mediterranean diet, feeling like it's healthy, is that they didn't look at panel B, which has been on the screen long enough for you guys to see it, that there was actually no decrease in mortality. On the right, just take a look at the primary data. Sure, the primary endpoint, the combined endpoint was reduced, but it was really reduced dramatically by reducing stroke. Myocardial infarction was essentially unchanged. Death from cardiovascular cause, essentially unchanged. Death from any cause, a hair more with the extra virgin olive oil and nuts, not too much. And so what we end up with is a diet that does not improve outcomes in terms of death, and being able to tell a family that, I'm sorry your family member died, but at least they didn't have a stroke. That leaves us in cardiology really lacking from what we want for our patients. So I would say that this is not a diet that people should adopt, since it does not improve myocardial infarction or death from any cause. Now, it actually does. So this is a publication from the same group where they take the data and reanalyze it based on the amount of vegetables people were eating. So if you look at it in terms of quintiles, the top quintile versus the most amount of vegetable, the top quintile for #1, that in terms of mortality, that is the people who are eating the least amount of vegetables, and then spread those quintiles out and compare the top and the bottom. And what you find out is the people who are eating the most amount of vegetables, almost an exclusively plant-based diet, had about a 42% decrease in mortality. So there is no question that we are able to improve outcomes with a Mediterranean diet if it is a vegetarian diet or pro-vegetarian, as they like to say. So it's something that we should consider, not just stopping the red meat, but stopping the chicken and the fish as well. Now, that's a good segue into some of the Harvard data that actually has evaluated this and shown that from the Nurses' Health Study and Health Professional Follow-Up, that there are no safe animal products for human consumption if you have any cardiovascular risk. So this data may not apply to everybody. You have to have at least one unhealthy lifestyle factor. And if you do, then you end up with an increase in mortality that you can actually see every time you take vegetable protein and change it to animal protein. Just 3% change would increase your mortality with poultry and fish on the Mediterranean diet, for example, by about 6%. Dairy is a hair worse. red meat is worse than dairy, eggs are worse than red meat, and processed red meat is worse than eggs. But there are no safe animal products for human consumption if you have cardiovascular risk. Now, if I show you the next slide, you're not having deja vu. This is actually 3 years later. It's the exact same title and the exact same concept, but it's actually Japan. And the data is pretty much the same. I would say the big difference is under cardiovascular disease, the fact that in the Japanese population, that increase in mortality that you see with red meat instead of vegetables and processed red meat being the same, that really hasn't been shown anywhere else. I'm not sure. I'd have to ask our Japanese cardiology colleagues why cardiovascular disease was the same when in the United States, processed meat is substantially safer than red meat. When you look at all-cause death, yes, processed meat was the worst, but for cardiovascular disease, came out a virtual tie. We have more data. We have another publication that was very similar in JAMA. We've had people looking specifically at processed, unprocessed meat, animal products. All of them, no matter how you look at it, there is increased mortality. And you could look at the graphs all you want. There's no question that people should be doing more vegetables and less animals to have less disease and less mortality as well as less illnesses. Okay, so where should you get your protein? From the Tufuda Beast. This is a Larson cartoon from years ago. And most people don't quite understand that vegetables do have protein. So here's a little graphic for you. The big surprise is that beef and peanuts are the same. That egg whites really don't have that much protein compared to quinoa. It's actually less. Compared to nuts, it's less. And probably the most important thing, which most of the dietitians will tell you that you need, animal products for protein. But then they tell you when you have gout that you better back off of the beans. Why? Because the beans actually have more protein. Particularly soy and lentils, have more protein than you would get from an animal product. So people, all you bodybuilders out there, could watch the movie The Game Changers, where you see a bunch of plant-based bodybuilders. Works out great. Fact of the matter is, the plants, if you carefully plan it, you will actually see significant gains, and you don't have the cardiovascular risk. What is underpinning the cardiovascular risk when you eat animals? This is one piece of it. TMAO, and I'll go through several, but this is probably the most impressive to me. You can look at the data from the Cleveland Clinic that's published in New England Journal of Medicine, talking about dietary phosphatidylcholine, beta-choline, that your GI tract flora that are very particular when you eat animal products. Probably the decaying flesh that people are eating changes the bacteria, and so they turn these components, dietary components, into trimethylamine, gets oxidized to trimethylamine in oxide. And the Cleveland Clinic's theory is that leads to progression of atherosclerosis, plaque rupture, and then platelet hyperactivity, so that it mediates heart attack, stroke, and death. And you see the highest quartile of TMAO levels is associated with more of the bad outcomes. And there it is, more platelet aggregation when you have a high TMAO level. And even if you're taking aspirin, you'd be better off with a plant-based diet, not having the TMAO, than you would by having the omnivore diet and taking the aspirin. Once again, we have to remember, it's not just heart attack, stroke, and death. It's actually heart failure as well. And so this may be a mediator, it may be an innocent bystander, but it does correlate that as the highest level of TMAO is the worst survival in heart failure patients. And that probably is because they're getting a lot of components when the TMAO level is going up. It's because they're eating saturated fat, the blood pressure tends to be higher, there's more sodium. There's probably a number of things that are intervened upon, as shown in this publication by Kyla Lara, showing that if you do plant-based intervention in people with heart failure, you will end up with a 40% or so lower risk of developing future heart failure. And so the Southern diet increases heart failure. The more plant-based you are, you decrease that risk. Now, it's not just heart failure, heart attack, stroke, and death. It's diabetes as well, as we've covered. This was actually categorized very well by Alicia Wilk in a review article, talking about every aspect of what increases with red meat, and most of them are substantially worse with processed red meat. What's wrong with it? In addition to TMAO, which you see on the left side from phosphatidylcholine and carnitine and the like, you actually have a variety of things. I would just pick out the heme iron, because that's something that was pointed out by the NIH AARP study, showing that if you were consuming heme iron instead of vegetable iron, that is iron from the blood of an animal, it is oxidized and it produces reactive oxygen species. And so this sort of cartoon really talks about the fact that it upsets foam cells, makes plaque unstable, and more ischemic events. We also have to mention the fact that when you're eating animal products, you're getting more sulfur amino acids, which means that's methionine and cysteine, which may be one of the mechanisms for the development of more diabetes. And that's what their data has shown. Now, I don't want to spend too much time on it, but people have been hearing some of the opposite. Last fall, when there was a group of self-appointed guideline writers that got published in as a clinical guideline in the Annals of Internal Medicine, saying that people should maintain their red meat consumption because it only made a very small difference. Well, there are a lot of methodologic issues, but more important, with this panel telling people to continue eating red meat and processed red meat, it was that there was a lot of people who involved with those studies and those publications who were conflicted by the meat industry. And so there was a large reaction. I think it actually helped get people to understand that red meat is not a good thing. And we saw loads and loads of reaction from very reputable sources, whether it was Harvard, American Heart, American Cancer Society, saying that there was an erosion of public trust, and hopefully that won't happen. People were going after the publishers of the journal and the editorial staff. Not easy when they're presented with stuff that they believe, but they probably should focus on relationships with industry. Okay. In closing, I want to talk a little bit about doing plant-based intervention. You've seen several of them, but we actually did one on the south side of Chicago in our vulnerable population in an African-American church. We tried to follow the ACCAHA guidelines, which had just been published at the time, recommending that we do much more in the way of vegetables and fruit and nuts, decreasing saturated fat and decreasing monounsaturated and polyunsaturated fat, and making sure that people were getting as little sodium and no cholesterol to decrease their risk, no processed meat, no refined carbohydrates, and avoiding completely any trans fats. So we did that actually by delivering vegan food to volunteers. It was President Obama's old church. They were very interested in health. And yet, when we took people who had the standard African-American diet and made this dietary intervention, we saw a decrease in blood pressure, in blood sugar, body mass index, of course, hemoglobin A1C. We saw a decrease in insulin that was actually tremendously large, 43%. And it was only matched by a decrease in trimethylamine N oxide, TMAO. We saw LDL density improve. We saw less C-reactive protein. The LP(a) levels went down. We saw a dramatic improvement in risk. We actually plugged the patients into the ACCAHA risk calculator, and that 5-week intervention with a pretty good completion rate and reasonable good adherence with the weight loss and the reduction of the biochemical markers of risk, it turns out that we eliminated about 19% of the 10-year atherosclerotic vascular disease risk by our risk calculator, which is almost all of the 21% increase that exists in African Americans. And so it's something that we really we presented the American Heart Association. Hopefully we will be able to continue to do these kinds of interventions because they hopefully are life-saving and life-changing. I want to end by talking a little bit about plaque because I know this is an active issue where people are saying, no, you really can't reverse plaque. And studies that have shown that are just one-off cases. Yeah, well, according to JAMA, that actually does work. And this is the Ornish diet showing invasively that there is a decrease in percent diameter stenosis. People will argue that if you use a 10% cutoff, then this doesn't really do much of anything. And maybe we need something physiologic. Well, Dean Ornish's group did publish that with Lance Gould doing rubidium-82 PET imaging with a stress vasodilator, showing that if you intervene with diet, you can actually improve myocardial blood flow dramatically, which is shown in this case with all of the blue ending up as substantially better over time. And that timing was about 3 months. We also have data from Caldwell Esselstyn talking about not just improvement in myocardial blood flow, but dramatic improvement in coronary stenoses with plaque regression. Now, it would be great to see a large randomized trial and incorporating statins or going without it and doing a comparative trial. But we do have data with high-dose statins that are similar. And my feeling, of course, is that we should be helping our patients who have cardiovascular disease by going in all fronts. And we should really do this. Heart disease mortality is increasing, driven by diet and exercise. Plant-based diets are associated with less risk, and the kind of risk that we should be trying to lower, particularly for our cardiovascular disease pandemic and our viral pandemic, because all of these diseases and outcomes of the risk factors are improved if we could get our risk factors down. People joke with me a lot because I did, when I took over as president of ACC, say that we would to try to go out of business in the next 2 generations. But to do this, we really need everybody on board. We need all the doctors on board. The leading cause of mortality in physicians and cardiologists is still heart disease. And so, we need to get back to looking at the kinds of things that produce heart disease in our lifestyles and being good examples for our patients, and try to get the patients to not have the approach that so many of my patients have, doctor, give me a pill so I can go back and do the things that got me here in the first place. And so Michael Pollan actually quoted this. I think it's reasonable. Eat food, not too much, mostly plants. I would just say, eat food, not too much, only plants. And I would also just remind everybody, which, David Katz, who used to be at the Yale Prevention, now is a True Health Initiative, when, everyone's talking on and on about diet and which one is best, he always wants to remind people that we do have a planet. We are going to hand this planet off to other people related to us. And now that I have grandkids, I listen very much to what he has to say. And so I would say a whole food plant-based diet, it would actually be a whole food planet-based diet, something that we need to think about when we're making our food choices. And with that, I'll end there and hope to have some interaction with everyone. And thanks so much for listening.